So, good evening, everyone, and thank you for joining us for this important and deeply relevant discussion on organ donation. Across the country, while we celebrate life and new beginnings, in an ICU, we often stand at a crossroad where science, ethics, law, and humanity intersect. As intensivists, we are comfortable managing shock, ARDS, ECMO. But when it comes to brain death and organ donation, there's often a moment of pause. Not because we don't know, but because we want to be absolute certain. Behind every potential donor lies the possibility of multiple lives. Today's discussion is not just about guidelines, it's about real decisions, real conversations, and real impact what we all make. So it's my privilege to be joined by an exceptional panel of experts who brings immense experience in organ donation and policy. So today I'm joined by Dr. Anil Kumar. Dr. Anil Kumar is the director of NOTO. NOTO is India's apex government body responsible for coordinating organ and tissue donation and transplantation across the country. He is involved in implementing the NOTO and ensures the compliance with TOTA Act. His recent initiatives are swab transplant program in April 2025. He led discussion on India's first national swab transplant program to streamline organ allocation for incompatible peers. His national vision in March 2026, he delivered a keynote address at Samarthan 2026 in Chandigarh, focusing on the national roadmap of public and organ donation. His public awareness is to continues to use media platforms like Akashvani and DD News to encourage citizens to pledge their organs as gift of life. Then I have Professor Dr. Rahul Pandit. He's been teacher, mentor, chairman of critical care and emergency department, Sir H.N. Reliance Hospital, and all Reliance healthcare initiatives. He is visiting consultant at ICU, that is Bathurst Hospital and Wagga Wagga Hospital, Australia. He's been a member of National Task Force appointed by Supreme Court. He's been chairman of Home ICU Care, and he's got more than 100 original publications, 60 book chapters, 1,000 plus lectures and scientific presentations, with special interest in critical care, echocardiography, ultrasound, brain trauma, and organ donation. Then we have Dr. Kapil Zirpe, again a teacher and mentor of mine. He's head neurotrauma intensive care unit. He's affiliated to Grand Medical Foundation, Rupi Hall Clinic, Pune. He's chair of Asia Ocean chapters of NSES, that is Neurocritical Care Society, Board of Director of Neurocritical Society. He's been president of Sepsis Forum, past president of ICCM, and he's written many books and chapters and more than 150 publications. Then we have Dr. Muralidharan. He's clinical director and coordinator, critical care lead in clinical audit. His affiliation is KIMS Health, Nagarkolai. His achievements are from MD anesthetist from GMC. His area of interest are fluid stewardship, humanizing intensive care, green ICU, brain death management in ICU, and sedation. Then we have Dr. Tariq Ali. Dr. Tariq is Senior Director, Division of Critical Care, Yashoda Medicity, Indrapuram, Ghaziabad. He's ex-director critical care Medanta Medicity with around 32 years of experience in critical care, intensive care training in Brisbane, Australia, and he's been conferred ICU Special Award at Meta Hospital, Brisbane. Ranked in toppers list in European exam intensive.
ले जाओगे क्या इससे रिंग रोड से
Special interests are multi-organ failure, ARDS, trauma, oncology, and obstetric critical care. So let's transition to discussion now. Let's begin by building a strong clinical foundation. Before we move into the more complex ethical, legal, and communication aspects, let's start by getting our fundamentals absolutely clear because confusion often begins here. So, Dr. Pandit, to set the stage, I want you to answer what are the key clinical differences between coma, vegetative state, and brainstem death? Because this is what a common people and we as the doctors also sometimes confuse and label and they misuse the term across all these terminologies, states of the medicine.
Thanks, Dr. Bharat. So, look, Dr. Bharat, the first and most important thing to understand about coma is that it's a word attached with a very bad name. You know, we always refer it to the coma movie, or coma sort of relates to a badness. Now, what essentially coma is, that coma is a condition in which the patient is not responsive. patient is unconscious and there is no chance that you are going to get a response when the patient is comatose. Whether that is reversible or not is a different question. So that's where the first differentiation is, that coma can lead to brain death, but not every coma is brain death. That's the first important thing to
Important.
remember. And
Yes.
how do you differentiate between that? So you would have no response perhaps, or a partial response to pain, or you will have your eyes closed, but you may have your brainstem reflexes fully preserved or partially preserved, and you may also have some amount of spontaneous breathing present. So that's the first thing which a coma talks about. Now, coma could progress on to three phases. Coma could eventually lead to a recovery. Coma could eventually lead to a persistent vegetative state, or coma could actually progress to a brainstem death. So these are the three things with which the coma could progress. Now, what's a vegetative state? Vegetative state is a severe brain injury or a severe injury to the brain, which could be because of any causes. It could be trauma, it could be hypoxia, it could be an infectious cause, it could be a cause secondary to a overdose or something which has led to a cardiac arrest or profound hypotension or something like that, which will lead to a state where the patient may open eyes, may be essentially having some amount of even eye movement, which people might feel that there is a tracking of the eyeballs happening. You may have patients who may have some amount of even facial expressions change, but they are non-purposeful. And usually these people will have a preserved ventilation and they would continue to breathe, at least trigger the ventilator, if not completely breathe by themselves. But many of them are able to actually wean off completely from the ventilator. Whereas brainstem death or brain death, and we would like to just call it from here on in the webinar as brain death. Let's not differentiate and confuse people. In India, brainstem death is brain dead. So in brain death, you have a coma which is irreversible, you have loss of all brainstem reflexes, and you have loss of breathing. When you have these three things present, that's when you say that this patient is brain dead. So these are the essential differences between coma, vegetative state, and brain death.
So yeah, very nicely described, and this is what is important for all of us to understand, because recently we came across a news article where we got to know this female came out of the brain dead after the ambulance was struck with the pothole. So of course she was not brain dead, otherwise technically it wasn't possible, and it was very disheartening to see many medical people also posting this. So it's very important to clear out there's a difference between the coma, vegetative state, and the brainstem death, and this is what.
Can I chip in?
Yes, sir. Please, sir. Please.
Yeah. See, what Rahul said is right. That there is always the confusion in between coma and brain dead. We need to come out of this social stigma. Coma is a social stigma considered to be the one of the worst prognosis. So that's why the definition of coma has been changed in 2020 to the disorders of unconsciousness. So we should start using the terminology of the disorders of the unconsciousness, and that will give us get rid of this coma, because whichever the news you are commenting, probably they are not brainstem death patients or brain dead patients. They were in a coma and they are in a reversible coma. So it is nothing but the stage of the disorders of the consciousness, either unconscious or the semi-conscious, and they regain the consciousness. So entire misuse of the terminology starts with the wrong terminology. So today is at 23rd March, 22nd March, we observe the World Coma Day, where we say the Curing Coma campaign, exactly opposite to the brainstem death.
Brainstem
So
death.
coma itself is a terminology we should stop using in a medical field. That is a better to for the future confusion.
Thank you, sir. Thanks for bringing it out. So now we move on to the next set of the questions, and we often say, as we spoke, brain death is a clinical diagnosis, but the way we approach it, it varies globally. So, Dr. Murli, this is for you. So, how does brain death determination in India differ from international practices? And is the current protocol overtly complex, or appropriately we need to be cautious about this?
Thanks, Bharat, and good evening, everyone. And yes, it is different and does not seems like a symbol. It's a bit complex, but conceptually not different from others. We accept brain death as a legal death as in any other country. Our Act TOTA is similar to that of UDDA from USA and ANSIX and UK guidelines. Coming to the legal framework of ours is embedded more into the transplant law. But others, in the case of others, they are focusing on to death law, which is more feasible, which can be adopted by us. We need four members for the manpower. to declare the brain death process, that is for the apnea test. One, one should be a neurologist and two empaneled doctors from the appropriate authority, but they need only one. And we need two test 6 hours, but they need only one test. And coming to the ancillary test, they have clear-cut guidelines where to use and when to use the ancillary test. We don't have that. There is no clear-cut guidelines about the ancillary test in India. We consider it as a legal event rather than a diagnosis, but they focus it as a diagnosis. We have to adopt that. I agree that is overly complex, but safer. Everyone will agree for that. Though it is procedurally heavy, conceptually it is very thin. For us, it's donation first and then transplantation. For them, it is transplant. For us, the tra- donation first and then for the death. For them, it is the vice versa. But it is we are sure that we are not cutting edges for the safety. We could continue like this with a slight modification with the noto suggestions so that we can focus on death diagnosis rather than death so that we can implement a good law here so that the slight difference even it becomes safer compared to that of others. It is safer.
So very important point you brought out, Dr. Muli. We were in a meeting 2 days back where Dr. Rahul and Dr. Zirpe, they used a strong terminology saying we should decouple brainstem death from the organ donation. And this is where we start. So to come up with that, then there's often a hesitation in initiating brain death certification and when donation is not being considered. This all we all know. So Dr. Anil Kumar, thanks for joining in. He's the NOTO director and which is the Apex organization who looks into all this. So, Dr. Anil, under TOTA Act, how is brainstem death legally declared, and should this process be initiated when organ donation is also not being considered? This is a very important question to be answered.
Yeah, yeah. Good evening, Dr. Bharat,
Good evening.
and good evening, everyone. And thanks for this initiative to organize this webinar. Brainstem death under TOTA is very well defined, and the process is also very well defined. And that how the form number 10 is there, which lists out all the tests. And basically, it mentions that what are the various prerequisites which need to be fulfilled or ruled out, or and then the various tests of the brainstem functions, and then the apnea test. It doesn't go into the detail how the apnea is to be conducted, but the as per the THOTA, it is the clinical testing which is listed out, and the uh, basically it is required that the full clinical examination of the patient who is suspected to be having brainstem death should be conducted before we declare somebody as a brainstem death person. And apnea test is to be conducted twice, which is also mentioned clearly. And a minimum interval in case of an adult should be 6 hours. So that is all clearly defined, and the who can certify, that is also very well defined, and it is for all purposes it is considered as a legal death. So, like when you are saying that whether when the donation is not happening,
Right,
so
sir.
can we declare brainstem death or not?
Yes.
So that kind of a clarity is definitely not clearly mentioned, but it doesn't. Obviously, it mentions that even the hospitals where the facilities are like which are not registered under this act, they also are required to request for organ donation whenever a patient is there in the ICU. And basically, to request for organ donation, one has to first identify a person as brain dead, and then only that request can be made. So that is very well laid down. So in a way, the brainstem death declaration is mandatory. Indirectly, when we say why it is mandatory, because why we say it is mandatory, because the rules they lay out that you are required to request for donation, and that request can be made only after determination of the person as a brain dead. And this And these rules they apply even to the hospitals which are not registered under the act. So in every situation, whenever a patient is there in the ICU and suspected to be suffering from, suspected to be a brainstem death case, so we are required to, certify him, because organ donation will happen once the family agrees, consent is given. But even if the organ donation is not happening, uh, still, so it is basically we have to decouple the two situations very clearly. And as per the law, uh, it may be misinterpreted as that it is only for organ donation, but it is just a misinterpretation. And it is not only for organ donation; it is for in every situation wherever the brainstem death is happening.
So, sir, I mean, thank you very much for bringing this out and you being an authority clearing it out. So, just want to pass on the message, and then I have the follow-up question also for all the panelists. So, brainstem death, as we all understand and misinterpret, as you rightly said, is not in the context of only organ donation. If we feel that patient is brainstem death, we can still go on to conduct the test even if family doesn't agree for the organ donation. Is that right?
Yeah, yeah, that is the way it should. It
Yes.
is.
So
So
supposedly, yes. So supposedly, on the follow-up question is, now I have done the brainstem death and family hasn't agreed for the organ donation. So do I have a right to stop the treatment, withdraw the treatment with the family's consent if the family allows it?
even if, because it is a medical decision, if somebody has been declared dead, so what we always say that because in a dead we should not continue the treatment, any kind of treatment, and we should be withdrawing the treatment, though it is not mentioned clearly as clearly. That's why we are, trying to bring this clarity in the new guidelines that we
Guidelines.
are
Yes.
drafting. But it is very unethical to,
Continue.
uh, continue the treatment when a person is dead. So, and brainstem death person is dead as per the law, and that has to be, followed. And that is the law of the land. So, and in every hospital, whether it is registered under the act or not registered, it applies to the same situation. Like it will apply equally in all the situations.
Yes, sir, very nicely brought it out. So, Dr. Pandit or Dr. Zirpe, just to one more follow-up, can we clearly withdraw it with the recent Supreme Court guidelines, what we had the landmark case also a few days back?
So, Bharat,
Yes.
let's put it this way. This is my favorite line, which I keep on saying. If you're dead enough to donate, you're dead enough to be dead, right? So you can't have two deaths within the same person, that you're dying and then you're donating, and but you're not dying actually to be ventilated to be withdrawn. So dead enough to donate, dead enough to disconnect. That's the that's the primary thing. However, a lot of people hesitate because, as Dr. Murli rightly pointed out, that the whole law was embedded into the Transplantation Act, and that's why there is this confusion. So you can still disconnect. There are a lot of things which may not come out very clearly even with the 2023 Supreme Court judgment or the recent judgment also. For example, time of death. We discussed it the other day, right? Whether you're going to put up a time of death on the certificate at the time when the heart stopped, or the brainstem death declaration was done. Ideally, it should be the brainstem death declaration, because you stop the ventilation only because the brainstem death declaration happened. So that is there. But the death certificate currently does not talk about declaration of death. It only talks about cardiorespiratory sense, not by brain death criteria. So there are things which are getting amended. To be very clear, yes, you can withdraw death. Right now, you can withdraw the ventilator if you have a primary and secondary board. You actually will be very much within your rights to withdraw it. Problem is, most states don't have the primary and secondary board. What Supreme Court judgment came out recently in the last week, that's a little different one. They did not talk about brain death person. Brain death person is dead. So this person was a persistent vegetative state, as we rightly discussed in the first slide. So there they actually talked about withdrawal of life-sustaining therapy in person who had no chance of recovery. But there also the primary and secondary medical board was involved, if you look at the judgment and read the judgment completely. So a lot of unanswered questions, Bharat, but morally, ethically, we should be able to withdraw. We withdraw. The only time of death becomes my concern because that remains a bit of a contentious thing when we talk with the family.
So just a straight answer. Someone has put
But
up
a
across this
straightforward,
question as well.
but a straightforward answer.
Yeah, sir. Anup Kumar Rana has put across the question. Brainstem death is not
Yeah, see,
allowed in law for non-donor.
but a simple and straightforward.
Yes, sir.
Brain dead is dead.
Yes.
Why you want to make it complicated? This end of life is nothing to do with the brain dead. It is for the non-brain dead patients, vegetative or the terminally ill. Don't confuse. Brain dead is dead. Brain dead is nothing to do with the end of life. This thing. Brain dead patient, you can withdraw the treatment, like Dr. Anil Kumar said very clearly.
In
There is
case
no
of
pointing
non-donor
when
as well. Sir, in
there
case
is.
of non-donor as
I
well.
am talking about a non. See, when we should make it a regular protocol in your ICU to declare the brain dead. If you are having the, if you are giving organ, then only you are will declare brain. It is a double standard. We are getting the softly targeted because of the our language change, our body language change, our words change. The moment they say they are not willing, we say that ki your patient is not dead. Then who will believe on us? Who will believe on the medical? And Supreme Court or any court never said that the brain dead is not dead. Every judgment they are saying that the brain dead is dead. Why you want a separate sentence from the law that you can go ahead and withdraw? It is impossible for the court to run the medical field. Why we are confusing ourselves? Why can't we practice the clear words? We are trying to get embedded in our laws and make us more safeguard. So what I do in my ICU, I am doing in my ICU. If the patient is brain dead, we give them the two choices: organ donation. If they are willing, we'll go ahead. If they are not willing, we are declare and we are removing the life support. That's what I am practicing in currently in my hospital, and this is our policy.
And that is the right practice. That's
Yes,
what
sir.
we should be doing. I don't think that Dr. Rana, I think he's a little
No, no, sir. This
misinformed
is
with the
actually
judgment.
it's not only him. This is
It's,
has been the teaching, old teaching or misinterpretation, as Dr. Anil rightly
that's
pointed
why
out.
first sentence I said, if you're
Majority
dead enough
understands
to
that way.
donate, you are dead enough to dead to be dead, and you're dead enough to be disconnected.
Yes.
So let's not get this wrong at all. Please go ahead and disconnect. If you followed the law perfectly fine by declaring the patient dead, please go ahead and do it.
And Dr. Anil Kumar very rightly presented it. I mean, for everyone to know, the law has been misinterpreted. It's not only as for the organ donation, it also exists for the non-donor as well. Dr. Anil, is that right?
Yeah, as I pointed out that the this requesting or in making inquiry regarding the regarding the possibility of this person becoming a donor, it also applies to it applies to every ICU, whether in a hospital which is registered under this act or not registered under this act. So in fact, so it applies to all the ICU situations. So it means it also applies to all the situations whether the donation is happening or not happening. So that is very clear because it applies. Otherwise, the donation would happen only in a retrieval center which is registered under the act, or in a transplant center which is registered under the act. But the provision which is there, it applies to all the hospitals. So correctly, we have to say that this making inquiring a person regarding his brainstem death status, that has to be it is totally independent of the organ donation happening or not happening. So irrespective of that, we have to certify a person as brain dead
Thank you.
if
Thank
he
you.
is a brain dead, if
Yeah,
he is a brain dead.
thank you to all the panelists. I mean, this was the burning question as it's very clearly been answered to all the delegates and participants. Thanks for answering this so crisply and clearly. So once we suspect brain death, the next challenge is ensuring that the process is accurate, standardized, and beyond doubt. So what are the essential clinical steps and criteria required to confirm brainstem death, Dr. Tariq?
Well, the most important thing here is that in India, we consider brain stem death, right? And there are some countries where you have whole brain death. So this creates a lot of confusion as far as the medical fraternity is concerned. So be assured that in Indian setting, the Supreme Court said brain stem death and not the whole brain death. So this is primarily a clinical diagnosis followed by followed by an apnea test, right? As far as confirmatory things go, then there are a lot of things that have come into being, which actually complicate it. Once an apnea test is positive and brainstem dysfunction or complete signs of absence is documented, there is no need for any other test. Only in situations where there is a uh, condition where you know uh, cranial nerve examinations or confounding factors are there, uh, then you can say, well, we can do some ancillary tests. The three types of these tests are something like, the EEG for that matter, a complete flat EEG. Well, there's no doubt about it that yes, there's no activity, but you have to rule out sedatives. And uh, the interesting part with EEG is uh, it's good if it's flat, but EEG can also show activity when the brain stem is dead. So that small focus here and there uh, that's spiking up some discharges, right, in presence of brainstem dysfunction, that again confuses the entire picture. Now, cerebral angio, well, that's the gold standard. Yes, but that sort of facility is not available at many other places. So I think, and second thing is about this, some people say about um, transcranial Dopplers, but it's highly kind of operator dependent as well. So one operator can have some result and the other can differ with it. In this setting, I would say that yes, uh, if it's done before the apnea test, well and good. But afterwards, especially the EEG and TCD, they create a bit of a problem.
Thank you. We move now, as you spoke about the apnea test. So apnea test is probably the most critical and often the most important part of this process. And it's also the most critical and anxiety provoking step as well. So, Dr. Kapil Zirpe sir, what is the physiological basis of the apnea test? And what are the key considerations regarding timing, contraindication, complications? And after this, then I'll have the follow-up question as well. First, you answer this, and we'll follow it up, sir.
Yeah, see, if you see the confirmation of the brainstem death, apnea comes last. You have to do the clinical examination, then you have to do the all cranial testing, and if they are positive, that means there is no response to all these things, then we final confirmation is apnea test. Why? Because it is related with the medulla. That means the respiration. If there is no respiration, then patient is brainstem death. And if there is no respiration, nobody can survive. Respiration is one of the key factors for the survival of the human being. So the physiology is very interesting. Actually, if there is an acidic media is created, and in spite of that, if your brain medulla is not getting stimulated and if do not have the spontaneous respiration, that means it is a brainstem death when the apnea is positive. So ideally, we should do the CSF and just find out the pH. If it is acidic and still patient do not have the breathing, then you can say apnea is positive. But we can't do the LP in this patient. So what we are doing, modified apnea. That means we create the acidic media by increasing the CO2, and the cutoff is 60. That's what the we have decided. And in chronically CO2 accumulated cases like a COPD, more than 20 from the baseline is a we consider as a acidic media. And in spite of that, if there is no spontaneous respiration, you can say apnea is positive. So this is a physiological basis of the apnea. Apnea is the confirmative test in India and most of the countries. If the apnea is positive, that means the patient is brainstem death. In India, we have to do the two apneas with the 6 hours gap to confirm the brainstem death after the clinical examination. And contraindication, the first contraindication if the patient is not brain dead. That is the first contraindication. If patient has a spontaneous respiration, if there are certain canal nerves are present, if there is a pupillary reaction, don't make hurry to declare him brainstem death. Probably he is not brainstem death, and you might be landed with the problem. So the first contraindication is your patient is not brainstem death clinically. Second is if there is hypotension, it is not allowed, because unless or until you complete the two apnea with the gap of the 6 hours, and if they are positive, patient is not brain dead, still there is a chance of survival. So hypotension, hypoxia, arrhythmias, then temperature less than 36, these are all contraindications for doing the apnea. You have to have a temperature more than 36, systolic blood pressure more than 100, oxygen saturation more than 94%, no arrhythmias, then only you can go ahead with the
What about
apnea
electrolytes, sir?
testing. And electrolytes, so sodium is range is 125 to 160. Generally, the upper limit is 160, lower limit is 125, and potassium more than 3, we take it as a go. And there should not be acidosis. That is a pH more than 7.25. These are the, you can say, the prerequisite for the apnea. And complications, the same thing. Hypotension, hypoxia, arrhythmia, or spontaneous respiration you have observed during the test, you have to abandon this thing. I have one of the rarest complications of the apnea is a tension pneumothorax. I came across the bilateral tension pneumothorax in a case. Fortunately, I was aware about this phenomena. So we put the ICD, we again ventilated, and we completed the apnea after the 1 hour, and we have retrieved the almost 5 organ for that. So one should aware about that, what is happening with the apnea, what are the complications, what are the contraindications. One of the another rarest thing is sometimes CO2 doesn't rise by the 10 minutes. Ideally, it should rise by 8 to 10. It takes 8 to 10 minutes. That means the 2 to 3 per minute CO2 rise in a normal lungs to above 60. But in some few cases, there is reported it may take more time. Like in India, reported apnea, which I was involved, was a 36 minutes. You need to wait till that CO2 goes above 60. And in Western countries, it is 110 minutes. These are the anecdote. But one should aware about that. They should not abandon. They should not withdraw. They should not postpone. One can continue if your patient is vitally stable. Interesting.
So one of the most commonly discussed the prerequisite is, I would like all the panel to take it. People also talk about the consent when we have to do the apnea test. So what is your take on that?
Consent is not required because it's a routine clinical examination. Yeah, are you taking the consent for the clinical examination to give the pain, noxious stimulus? Are you doing the, when you are doing the cranial nerve testing, are you taking the consent? And in ICU, suppose he is not brain dead patient and you are doing the so many tests and so many this thing. Are you doing the, are you taking the consent for that? Then why you are raising the question for the apnea?
Yes. So it's not a prerequisite. Consent is not a prerequisite for the apnea test.
No.
Yeah. Very rightly said. And also, sir, we spoke about, Dr. Hall, you may answer this. We spoke about the prerequisite. So we talk of stopping the sedation and the relaxant. So what should be the time lag in between stopping the sedation, relaxants, and going for the testing?
So if you have normal renal function and normal liver function, 5 half-life is what we should be waiting minimum. However, if there is any iota of doubt, wait longer. Do not wait shorter. Wait longer if you want to. Okay. So the ideal physiological answer is 5 half-lives. But if you have any doubt, wait longer. It doesn't hurt in waiting for some more time. If your renal function or kidney function is liver function is abnormal, consider waiting even longer. If the drugs which you have used for sedation are like phenobarbital or thiopentone, I would be very, very worried to actually just wait it for 5 half-lives, because those drugs are known to act for a long, long time. In that case, even consider doing longer waiting periods or dialysis if required with charcoal hemoperfusion. If you really think that this person is brain dead and there is no other way of coming out, so you'll have to sort of do charcoal hemoperfusion to take these drugs out.
That is
But
for the
these are
thiopentone and diazepam, yeah.
Yeah, but these are rare cases, Bharat. More commonly, people are on fentanyl, midazolam, morphine, propofol. So you really don't come across. These are very, very outliers. And for outliers, there is always help available. I don't think we should be emphasizing too much on outliers. For people who are fitting, the patients who are fitting the 80 to 90% of the criteria are the people who are getting normal sedatives every day. And most intensivists are very aware of the effects of the drug. So you will see that if a neuro case comes, which is what these patients are, they will automatically switch to propofol because they want to assess the patient every day in the morning. So gone are the days where we would be doing deep sedation. When would you be doing deep sedation? When ICP is a problem. That's when you put them to a deeper sedation, you paralyze them. So there was a discussion the other day about train of four as well. So if you have a doubt that you have a muscle relaxation which is lingering and you have waited adequately, but you still doubt about it, then the only definitive answer is to do a peripheral nerve stimulation using a train of four and see if there are four twitches present or not. If the four twitches are present, you can be assured that there is no lingering muscle relaxation. So again, these are all outliers. Do not complicate. I mean, this is not for you. This is for the people who are listening.
For us as
Let's
well.
not complicate the outliers with the maximum number of patients who are actually pretty straightforward. But that's what is important to understand.
Thank you. And Dr. Anil Kumar, just a statement for you. So you agree consent is not required for the apnea testing?
Well, definitely it is not required. And because apnea testing is a part of the process of brainstem death testing. And as I said, if there is a brainstem dead patient, one should be testing. And this and apnea because to explain or to seek consent because it's a medical decision that you are testing for. So why should for a medical decision you require consent from a person who is not so knowledgeable about it?
Yes, thank you. So we've been using ECMO quite often these days, and with the increasing use of ECMO, we are entering relatively uncharted territory as well. So, Dr. Rahul, can brain death determination still be performed on the patient being on ECMO? And if yes, then how do we do the apnea testing in these patients?
So I think with ECMO coming up, we are going to see more and more patients being declared brain dead, especially with the complications of ECMO, hypoxia-related swelling of the brain causing raised ICP, sometimes ICP, sometimes intracranial hemorrhages because of the anticoagulation which we do. Sometimes the patients may even have an infarct because of hypoperfusion area. So I think these scenarios are going to be more and more common, and it's important to do an apnea test and declare these patients brain dead so that you can easily prognosticate. It's probably not going to be organ donation coming out of many of these patients. Perhaps you may come out with some organ donation as well, possibly. But important to sort of first diagnose brain dead, decouple the two things. You can do it. You have to stop the sweep gas flow and allow the carbon dioxide to go up. Bring down the FiO2 to a level which is acceptable, where the PF ratio or the PaO2 remains above 100 or the saturation remains above 93, 94% on the oxygen that you are giving, FiO2 that you are giving, but the sweep gas flow has to go down and allow the CO2 to rise up above 60 and see if there are any ventilatory effects or ventilatory breathing efforts or not. Big thing about ECMO, Bharat, is the question which we answered previously. Most ECMO patients are on some sedation. Awake ECMO, not everybody does awake ECMO right now. So these patients, if they are on sedation, be aware of the sedation and the lingering effects of sedation. Do not hurry and do it. If these patients are fit enough and you can go and do an ancillary testing in form of a four vessel angiogram or a CT angiogram, just to sort of help your confirmation of the diagnosis, you could perhaps do that beforehand and then go ahead and do an apnea testing as a normal thing. As of now, ancillary testings are not a part of our TOHA Act. So people are not using that to confirm brainstem death declaration. However, scientifically, it is the best test to do if you are not able to do an complete brainstem death testing. But if you're able to do the brainstem death testing, the diagnosis is still clinical, and on ECMO, it should not change. It should still be clinical.
So yeah, next we move on to Dr. Tariq. Dr. You have kind of answered this question in your previous question. So again, just for the sake of it, when should ancillary investigations such as ECG, cerebral angiography, and TCD be used? And you've spoken about the limitations. If you could just frame it in a line, and then we move ahead. Yeah.
Yes. So, just for the trainees who just recently joined, uh, see if the question is asked that are ancillary tests actually required in India? So, the answer is no. PhD, the brainstem certification or test is basically a clinical diagnosis, absence of brainstem reflexes, and a positive apnea test done by two set of examinations, 6 hours apart. That's what is actually required. They're only and only used in very specific situations. We have said that okay, if somebody's had a facial injury, a compounding affecting the eyes, where you can't do corneal, conjunctival, or the pupillary, and then ear, of course, ear injury, or profound confounding something like intoxication, etc. That's where you do it, or any metabolic disorders. So, and limitations I've already discussed. Yes. So, CT angio, again, well, it's a gold standard, but it's not available. Two, transcranial blockers, again, very highly operator dependent. And EEG, of course, yes, it can be, it can have some spikes when there's brain death. So, yes, one should not focus on ancillary tests immediately because that confuses the entire thing. But once apnea test is okay and everything is done in a normal, say a patient of stroke, he's got his eyes intact, the ear intact, you can have all clinical examinations done, and then physicians, I've seen even neurologists, they start hounding the intensivists that, oh, why don't we do an EEG? Well, EEG is not really required when you've already done an apnea test.
Yeah. So we have the follow-up question, Dr. Zirpe, Dr. Rahul. It's come from the Vasudha Singhal. She's herself a neurocritical care specialist. She's put on a googly saying the DSA may show intracranial flow in a patient with an isolated brainstem lesion, example pontine bleeds. How it can be a gold standard in such a case?
See, Vasudha, DSA will not have this type. The CT angio may have a 10% positive rate, but DSA is the gold standard. If the DSA shows there is no this thing, then and these ancillary tests are ancillary tests. They are not the conformity tests. What Dr. Tariq mentioned very clearly, when you have a irreversible cause of the coma, you have rule out the confounders, you have fulfilled the prerequisite, you have done the entire clinical exam, you have done the entire cranial nerve testing, and if there is apnea or with apnea or no apnea is available, and then you are doing the ancillary test, it should not be great. But DSC is the gold standard. CT angio may have such issue. I hope I have answered.
I agree, Kapil. I think you never go across and do a brainstem death or a DSA on a patient who has a isolated pontine bleed and who has no signs of brainstem death, no clinical signs of brainstem death, like absence of all reflexes, not triggering the ventilator, unresponsive coma.
Yeah, the
So
locked in also we
it's
have
never
told.
an isolated pontine bleed. It is always the brainstem which gets completely affected and herniates, and you basically have a increase in your intracranial pressure. If you do not have that, you will not be going ahead and doing any testing. So the four vessel angiogram is the best amongst all of them, and that is proven by a far shot. It is not probably the most convenient amongst all of them because it's not a bedside test. It requires a cath lab, it requires expertise, it requires a catheter guided precision, so on and so forth. So hence people resort to CT angiogram, which is the next convenient one, but not the best one because it has got a 10% false positive rate.
The most important thing I am repeatedly telling, all these tests are at the end, not at the start. So when you are almost confirmed and you are just putting the final stamp, it is either apnea or ancillary tests. Ancillary tests are still not very much accepted in the Indian scenario. So apnea will give the answer of the such questions. And in addition, if you are doing, then it will be easy to
So she's
correlate.
asking, can we say DSA is a false positive sometimes?
No, but you can say that DSC is a still gold standard. CT angio might be this thing. And false positive, you are making somewhere confusion whether this patient really had all clinical and the brainstem and the cranial nerves not present and your diagnosis is this thing. Then only you can say that.
So we'll move forward. It's for Dr. Anil sir, so as we have discussed this, so is family consent required for brain death? So part of this question has been answered by you, but in certain cases, we often face a resistance from the relatives where they really come up and say, "Okay, why did you perform this test? Why was it done?" So how do we handle this? Sir, you have to unmute yourself, sir.
Yeah. So, when the relatives, if they're, yeah, definitely, matlab we can counsel the family regarding this, that there is a situation of a suspected brainstem death, and we would like such a test can be explained. That is not a issue that the family can be informed about, that this test would be conducted because the person is, his brainstem, he's a suspected brainstem death case. So, then if you explain everything, it's a sort of a not hiding the information. We have to be transparent. That is not a issue, that we need to be transparent whenever we are doing any kind of a intervention. But consent definitely is not required, because that apprehension that brainstem that testing may cause damage to the brain, some of the clinician may be having that apnea testing particularly may cause, but if apnea test is performed by a trained person and as per the defined protocols, it is very well, it is not supposed to cause any kind of a damage, or and so it is a medical decision, and we have limited resources in the ICU, and it is also unethical to continue to treat a dead person. So that is also a challenge. Tomorrow we can have another question from the family, that why have you continued to treat a brain dead person? So that is also another side of the coin. So
Yes, sir, got this. Uh, so
so that has to be handled, by being transparent, and continuing to counsel the family members regarding this.
So it's very rightly said. We need to be very transparent, and we have to say this is part of the clinical examination, and we just
Yeah.
did this as in clinical examination. The information what we incur from the examination are we transcripting to you. So there's no harm in doing this test and being worried about family being resistant about it.
Yeah.
So it's just part of the process and informing the family and prognosticating them about the patient outcome.
Yes.
Yes. So as we said, we know we have to decouple the brainstem death and the donor management. But of course, donor management also becomes very important once the brain death is confirmed. The focus shifts from diagnosis to preservation of life for others, if at all the brainstem death patient's relative agree for the death. So just to cover it up, so once brain death is confirmed, what are the key priorities in managing a potential organ donor, and how aggressive should we be with the organ preserving resuscitation, Dr. Murli?
As all panelists have agreed that there are two ways we can proceed. One is adopting withdrawal of life-sustaining treatment or focus on donation. So, as you
Yes.
correctly said, you have to switch from brain preservation strategies to organ preservation strategies to control the hostile physiology due to the brainstem death due to the rostrocaudal syndrome. So, leading on to myocardial stunning, requiring inotropes, vasoplegia, requiring vasopressors, diabetes insipidus, leading on to hypernatremia, requiring vasopressin, and neurogenic pulmonary edema, trauma-induced coagulopathy, hypothermia, and so on and so forth. If we are, if we can start this organ preservation technique as early as possible, as you know, the time is brain, like that time is organ here. So that we will have to start the brain organ preservation techniques as early as possible and can be continued for 48 to 72 hours. For that, we need protocolized management, which has got evidence-based support from Kapil Sirpesas. Our own ISECM has come out with a position statement, along with the SSCM is also having a position paper. Our own ISECM have revised it with the Kapil Sirpesar in 2024, which is an absolutely evidence-based material, which gives us a protocolized, targeted, aggressive resuscitation to prevent a hostile physiology to develop so that we can preserve the organ and bring out the organ and increase the organ pool and decrease the number of organ rejection and organ uh, that is utilized organ can be increased. There is no much difference between SECCM guidelines and ISCCM guidelines in 2024. Only difference found in the endocrinological management. The endocrinological management in the case of thyroid support. All other bullet points are similar to that of SECM. So we can clearly adopt these guidelines, ISCCM guidelines, updated by Kapil Sirpe sir in 2024 will be a reference material so that we can adopt that. Any trainees can adopt this policy so that aggressive management can be adopted by this.
Thank you. So, Dr. Zirpe, sir, basically, we all know this when we come across the organ donation, most commonly practiced is the kidney, but sometimes it happens so patient has AKI, creatinine is 2, we are not very sure whether this can be transplanted or not. But because of that, the whole process goes off. Even the liver goes off, the heart goes off. So, how should this partial organ donation be handled?
Two different parts.
Yes, two
Whenever
different
we
parts.
declare the brain death, which organs are suitable, viable, and which organs are not suitable, viable. So kidney, if suppose nephrologists are taking time, just offer the rest of the organs and start doing the that process. If suppose the creatine 2.2 and the nephrologists are not very keen for taking, we can put the two kidneys into the one patient if at all that is a issue. So there are the numerous solutions. We are not in situation to reject any organ. Bharat.
Yes, sir.
One should not reject acute
But this
peritonitis
happens
is
very
not good.
commonly, sir. Liver gets
No,
rejected when the sodium is
because we are not
155.
doing we are not doing audit. Anil Kumar sir must be agree. We should have a audit. How many declare? How many organs retrieve? How many wasted? What was the reason for the wasting of the organ? Whether they can be usable? How can we avoid? Where we are nowhere in our audit. That part is different. Will not dilute. Partial means what happened? Suppose the liver size is big and the two patients are waiting. You can have one adult and one children or two small adults. So that is what the split liver is very common. They are doing in organ transplantation. Actually, the split lung is not in a cadaver organ. Split lung is in a live patient. The one lobe one can give it to the this thing. So lung, kidney, liver, split liver is very common. So that is how you try to utilize the maximum organs. You try to save the two lives. With the split liver, you can save the two small adults or the one adult and one child. And that is what the concept of the split. But auditing is very important. We are not doing the audits. We should not waste the organ. Bottom line.
So audit will start, sir, once we realize this brainstem death is different from organ donation. We first is start identifying brain death.
Don't club, don't
Yeah,
mix.
that is
We are
what.
discussing
Yes,
the organ donation. Let's do the audit of the brain dead patients. How many declare, how many consented,
correct. Yes,
out of consented, how many retrieved. Like what we promote 8 to 10 organs. How many times you give 8 to 10 organs? How many times you retrieve? If you see the 2025 statistics, Tamil Nadu has a maximum, I think 4.55, including the tissue. Maharashtra is 1.6 including the tissue. That means we need to wake up. We need to wake up what we are doing. Suppose 1,000 donors declare. Ideally, there should be 5,000 organs should be retrieved. What is the statistics? 2.6 to 2.8 thousand organs are retrieved. So where those gone? 2000 to 2005. That we should try to first. So we should not aim for number of declaration of the branded donors. We should aim for number of retrievals from the branded donor. So our retrieval rate should be the audit KPI rather than the number of donors. Even if I do the 10 donation and the 50 organs retrieve, somebody does the 12 donation and the 12 organs retrieve. So I think that 10 organ with the 50 retrieval is the champion rather than the 12 who is doing and having the only 12 organs retrieve. And that is audit we should. It is known as the conversion rate. We should have the display the conversion rates of the every institute who are doing the transplant. Their conversion rate is 50%, 60%, 70% like that.
Bharat, I
So
think the important thing for intensivist in this is absolutely don't want to cover onto what Kapil has already covered. It's 100% correct. For us, if there is a very clear indication that XYZ organ will not be donated, for example, there is a CKD patient who is on dialysis, then you don't need to concentrate on keeping the kidneys well filled or the CVP well filled. You can actually think of other organs. Say, let's say the lungs are good. You will think of trying to keep the lungs a bit dry. You will try and just optimally keep the CVP so that the heart and the pressures of the heart are pretty good and the blood pressure is well maintained. So if there is a clarity that one of the organ is absolutely not going to be taken up, then you can actually concentrate onto the other organs and have a better one. So if all 8 organs are going to be taken, you will always have a conflicting. The kidney guys would want the patient to be well hydrated. The lung guys would want it to be a little bit on the
Right.
drier side. So that balance, of course, as intensivists, we all know how to do that. That's not a difficult thing, but that's the only thing which you should think of from maintenance point of view. Otherwise, everything what Kapil said, I don't want to repeat the discussion. It's absolutely perfect.
So one question is come in the chat box by Dr. Nong Saba. Dr. Anil, this is actually for you. So as Dr. Kapil sir said, when there's a borderline kidney, we can transplant both the kidneys to one the patient.
No,
But
don't
what is
misquote. Don't misquote. I said normally it should be one will be retained by the hospital and one will be there. So two will be two patients. But in patients where the because of the creatinine, diabetic, and
yes,
the comorbidities, nephrologists are not willing to take this thing, then those nephrologists who are willing for the two kidneys in the one patient can go ahead.
yes.
Completely don't misquote. It is a very
No.
simple and straightforward. So there is no law. Law says one should go to the as per the ZTCC or Rotosoto this distribution, and one can be retained by the hospital. That is true. There is no change in the law.
Yes, so one goes to one center, other to other center. When both refuses, then we can come back to the Noto Soto of their area and talk of this possibility of two kidneys going to the one, if at all nephrologist agrees, right, sir?
Yeah, yeah. And those who are with a compromised kidney, we are talking about a compromised kidney. Your question is partial organ donation
Right,
and
sir.
what is so it is pertaining to that. If the compromised kidney, the see, nephrologists are not very keen for more than 60, 65, you diabetic, creatine more than 2, and there's a choice to the relatives. Relatives can refuse. Anil Kumar sir, actually that point need to be discussed. Ki relatives have the entire right to refuse this thing. If you go to the relative and say creatinine is 2 and he's a diabetic, the relative says, no, I don't want to get. So whether his number maintains or he comes down in a list, I don't know that part very well.
Yeah, you're right, sir. We have to be very transparent, and whenever there is a marginal organ
Yeah.
that is offered to a patient, the patient should be informed about it, and we always insist that they should take a high risk consent if it is a very highly marginal organ, so that high risk consent should also be obtained from the patient's family.
So in the continuation of the same, Zirpe sir, this is for you. So when and why should organ donation be discussed with the families, and how do we ensure, and whom should it be discussed with, and how do we ensure that trust is not compromised in all this process?
Ideally, Indian system is an open system where the primary consultant who admits and who is the primary consultant, the families are well connected with that. So we need to keep them, even though our ICU, the open ICU, the primary consultants are the patient owners, but we manage. But we have to have a very clear rapport with the families and the primary consultant. We have to build up that trust. No new guy should come in front of them when you are declaring the breast death. So trust, I connect. Communications are the keys in the family communication. Most importantly, in if you see the Western world, they have the teams. They have the transplant team. They have the various counselors. They are the coordinators. In India, we have that. Even in my hospital is a separate department of the social worker and the transplant coordinator. But I will never introduce the transplant coordinator directly in the discussion of the brain death. I have to take them during the few initial sessions of the counseling so that their face become familiar with the family. All of a sudden, new face, though it's a 20-year-old experienced transplant coordinator and starts saying that, okay, let's discuss your patient is declared branded, shall we go ahead with the organ donation? They will never say yes. They will say yes to their primary concern. They will say yes to the treating doctors, which are the familiar face. They have seen that you have done your 100% to save the life. They should see your efforts. Then only they will be agree. All of a sudden, you cannot come into the picture and say that. That's why it is a overlapping. primary consultant, treating intensivists, and the transplant coordinator. They should have a very good communication and the rapport, and who will enter into the discussion at what time is very crucial in Indian. I'm telling you the Indian scenarios. Then there the chances of the convergence are very high. No new face, the relatives will be ready to discuss the very sensitive matter like organ donation. So we have to build up that in a various sessions. It is not the one session. In the morning, I said your GCC is 3. In the evening, I said the patient is clinically brain dead. Next day, I did the apnea and said, let's discuss the organ donation. It never happens. And for that, the families must be highly devoted. Some families are extraordinarily devoted. They will come to you and say that, Ki, doctor, we know that he is likely to be brain dead. Is it possibility of the organ donation? Okay, that's a very straightforward affair. Call your transplant coordinator and ask them to discuss and declare it properly.
Dr. Tariq, what communication strategies have you found most effective in improving understanding and consent? So, what Dr. Zirpe sir has clearly explained. What is your take on this, and what process you follow in your scenario in when you come across that kind of a case?
See, as far as the concept of organ donation is concerned, right, it will arise only after brain death, right? So, to get a yes or uh, even putting this topic forward, one thing is very clear that the family has to understand what is brain death. Mean they have to understand it very clearly. And sometimes what happens is uh, they many other doctors or some junior person they go into medical jargon, right? So stop using the words like deep coma. Straight away say that this is not coma, this is brain death, and brain death is death, right? It's irreversible death. Once they understand that, right, now you got to give them time for the entire family and the extended family that yes, it's this. The doctors have confirmed it not once but twice, and uh, you also encourage the other family members, the main family members, to involve or talk to other extended families so they are also accepting, right? Uh, the other thing is we should always have a grief counselor. So a grief counselor is there with the family from the first few to the last uh, uh, conversation. Now, never should a third person come in the beginning. What we generally do is, which has worked well, is that the transplant coordinator uh, and one or two more social workers, right? So they come forward as a team, not really as uh, asking organs, but that yes, involved in the part of grief counseling. Then once the patient's attendants have agreed uh, to a donation, then I think it is the transplant coordinator who will then take over from uh, the main consultant. And now it's the social worker, grief counselor, and the transplant coordinator who take. That's how I would address this.
So,
And never, rush in the family to take, jaldi decision kariye, jaldi bataiye. Now that all becomes very counter
um,
counterproductive. Yeah.
So, Dr. All, we have discussed this kind of, but we know once family gave a concern, we declare the patient brain death certification, then they withdraw the consent, or maybe we have declared BSD and families doesn't agree for the organ donation. So, what are the ethical and legal considerations regarding continuation of the support?
Look, Bharat, we should be withdrawing the therapy and handing over the body to the patient's family. However, you and me work in the real world. all of us work in the real world. If the family is going to vehemently oppose and just say that you cannot disconnect, they're going to threaten you and stuff, you keep on doing conversation with them. See, the problem with most of us is that we take this discussion as a one point stop scenario. It doesn't happen that way, right? We keep on talking. Once there is an acceptance of death, that's when you can actually go across and withdraw as well. If there is no acceptance of death at all, if there is no trust on what you have done, then the whole patient doctor relationship is broken out here. So the patient doctor relationship is the most important thing. And that's why your previous question, which Dr. Tariq so elegantly answered, you need to be communicating without medical jargons. You need to be communicating directly. You need to be telling things. And this is not just you or me who are communicating with them. It is the entire team, which includes nurses, which includes bedside people who keep on saying one same language, that he is no more or she is no more, he's dead. If all of them say that, then that's when the clear message will go across. Also, I gave you some other day, the other day I mentioned about few anecdotes which I use for people to understand. We talk about life. Life is when you breathe. If your breath is taken away, it's not life. In a common language, you say, इसने आखिरी सांस ले ली. आखिरी सांस ले ली because पहली सांस जब हमने पैदा हुए थे तभी ली थी. And that's when we celebrate our birthday. Otherwise, the heartbeats were there for several months before we were even born. So heart is not life, breath is life. And secondly, the reflexes with which we are born, the primary reflexes with which we are born, then once they are gone, you are no more. So when a combination of your unresponsiveness happens, when a combination of your brainstem reflexes, which are primary reflexes, which you don't need to learn, they are given to you naturally, are lost. And when your capacity to breathe is lost, that's when you die. If you actually do this conversation over the several hours before you actually go and do a brain dead testing, the acceptance of death will come and withdrawal will not become a problem. Now, ethically, it is perfectly fine to withdraw. Legally, it is perfectly fine to withdraw. So that's your two questions were there. There is absolutely no doubt in our mind, anybody's mind on this panel, that you cannot withdraw. Both ethically and legally, it is absolutely fine. But nobody fights and withdraws a tube. Everybody assents the family, understands them, and then withdraws in a cordial manner. I have never done a withdrawal where the family has not accepted a futile outcome as a death. If they say कि कुछ नहीं हो सकता, no, they have to accept death as an outcome. Then you go and withdraw.
So very rightly put it across. So we all agree ethically it's not right, legally it's correct, not correct to continue with the life support. But at the same moment, we cannot be pushing on the families for both the scenarios. May it be the organ donation or may it be the discontinuation of the life support. If the family was to come to a consensus with our regular counseling, it cannot be a one point decision, as you also rightly said, a one point meeting with the family. So it's a dynamic process which has to be built on over a period of time, and family has to build a trust in you. Then only this can happen, and we can't be rigid. We have to be flexible in this because the legal and ethical consideration might be different. But at the end of this, we are looking after the families as well.
Yes, Bharat, I just want to put in one more thing
Yeah.
that just as a legal example, you can take this one as the court's understanding of brain death, right? And this is clearly reflected in Dr. S. Ganapathy versus the Union of India in February 2025. And there, the court has clearly said that brain death means irreversible cessation of all brainstem function. Once certified, the patient is already dead in law, and the life support then, or the artificial support, can be removed. This is there in the court ruling.
So confusion comes
In
among
other way,
Removing of ventilator is not euthanasia
yes,
in a legally dead person.
Bharat, in other way round, Bharat,
yes sir, yes sir.
in other way round, if suppose the relatives go to the court that ki you're declaring brain dead and you're not withdrawing, then how you will
I
defend?
will
Why
safeguard
we
it.
are putting it
Yes,
in other way
yes,
Correct,
perspective?
correct, sir.
You should be
yes,
having the fear of more. You are ventilating the dead. is a big news
Yes.
socially and financially as well as legally. You should be worried about that more. Why you are discussing that the how many times you will disconnect? I think we are taking it law in a different perspective. We need to.
Perspective.
I am worried about my reputation and my this thing rather than law because
In
they
fact,
can
this way you are
say that
safe,
you
sir.
kept it on the ventilator.
As you rightly pointed out, otherwise we can be in a problem when we continue the patient and patient comes goes to the legalities court of
But
law.
your
We could
declaring
be a
brain
problem.
dead. Rahul is saying dead. 10 times you are saying dead. And when you are saying dead and you are continuing because you are not sure what to do, then we are in a trouble.
So there's
See,
also a
if
loophole
you
we all are
continue
worried
to
about.
ventilate and do not talk about withdrawal and do
Yeah.
not withdraw the therapy, and the patient family goes to the court,
We are in a
it will be a severe recommendation by the Supreme Court or any court. Forget about Supreme,
Yes.
even the local court will actually look at you in a suspicion that you are making money out there and you are falsely doing, and it's unethical. Then that legal and ethical, it is illegal and it is unethical. Both the questions are
both.
there.
Sir, also there's also a loophole. I mean, many people talk of MLC है इसको कैसे कर सकते हैं? So how do you answer that question?
What MLC?
मेडिको लीगल ट्रॉमा है, ये है,
Oh,
पुलिस का क्लियरेंस
see,
चाहिए
but,
and all चाहिए.
again, don't confuse. We are not talking about medical, legal, or no, MLC or non-MLC. We are talking about the death. So let's talk about the death. Whether it is a MLC death, do you think that the MLC deaths are different from the non-MLC death?
No, of course not. But there's always people think of it. पुलिस केस है मैं कैसे करूँ? I need a
See,
clearance of the
don't go
police.
by the people thinking we are
No,
a
no. So
soft
yeah, I'm
targets and
saying that.
we are having a very bad reputation in society. So don't go by the what people thinks. People will never think in favor of you. And if you are in a corporate hospital, there is no way they will think in favor of you. So in fact, think logically. Now, if you are saying dead and you are continuing, it is
No,
very
no. So
difficult
my
to.
question is, if supposedly there's an MLC, there's always been
Yeah,
understanding people say कि we need a clearance of police. So is that required or not?
no, ridiculous. Follow the formalities. If it is MLC, go to the postmortem. If it is non-MLC, give a cause of death.
Bharat, if the
Yes.
heart would have stopped, would you inform the police that the heart
No,
is
of course
stopping?
not. Of
I
course
mean,
not.
10 minutes heart is
No,
stopping.
no.
Right? We do that all the time, right? Maximum people die with cardiac arrest,
Yes.
cardiorespiratory arrest rather. We never bother about whether the patient is MLC or not. We just go ahead and declare the patient clinically dead. We check the pupils, look at the heart rate, do the
Yeah.
ECG. Sometimes you document the ECG and keep it in there. All of these things are done quite regularly, right? Why should it?
And Bharat,
Yes, sir.
on other day, Professor Anil Kumar said very rightly. In death certificate, is it there a column that you write the heart stops or the brain stops, the brain dead or heart stop? You say he died because of the acute myocardial
You part
infarction
of that meeting.
or trauma or sepsis. You never say his heart stop and we declare, or he's a brain dead and declare. Even we never give a cause of death as a cardiorespiratory arrest. It is not the right one. So
Yes. So I understand. I was part of that meeting as well. Is the overall understanding of the people, and it's come in the chat box also.
So
And these are
the
the common points.
questions are answers are directed to you, but they are not meant for you. They are meant for people who are listening.
Yes.
So bear with us as well, because you are answering the question, so you are getting it back.
Yes. Sir. So we'll move on. And so organ donation system in India, and this is again for now again we let's zoom out now and look at the system level perspective and come to Dr. Anil sir. Sir, how are transplant programs regulated in India, including hospital licensing and certification panels? Because across the way, though it's one nation, but the system is not one. I mean, we've been to the different areas. Some has the ZTC, someone has the SOTO. We were talking of ROTO, then now NOTO, and there have been areas in the east where they say this can be practiced in the government hospital but not in the non-government hospital. So how do we align all this, sir?
So basically, organ donation and transplantation in India is a government regulated activity. So that is so wherever, like if you want to do any organ retrieval or organ transplantation, so that place has to be have a license, or we call certificate of registration, and that is given by the state level authority, which is a appointed authority by the state government. So wherever the hospital is located, like you cannot do transplant or retrieval in a hospital which is not having a license by the state government. So that is one thing. So place has to be registered. People who are authorized to do, they are also, do the transplant or retrieval. They are also mentioned in that approval forma which was received. So after they have obtained this license, they all have to be, because the central government has been given this mandate to have a network of these hospitals which are doing organ transplantation or retrieval or tissue banking, and form a entire network. Why this network is required? The network is required because we want everybody to be connected through to have an efficient system of organ procurement and distribution in the country. Somebody who requires organ from a deceased donor, he should be registered with the network. And then how the registration will be done? So registration is done by the transplant hospital where he is going to receive the treatment. So it is not done by SOTO, ROTO, NOTO, JETCC. So it is done by the hospital. So hospital has to have a license. So there people, they advise, the treating doctor advises the transplant, and then the patient is listed in the waiting list. So they are listed. So we have waiting list, which is hospital, in the hospital, in the state, or within the state. If we have zones like JETCC has, the other states also have such zones. So these systems are there. And once the patient is listed in the waiting list, so once the donation happens, that information will go to the SOTO, the concerned state organization, which will look at the waiting list and allocate the organs to the patients in the waiting list. So whether the patients are there within that donor hospital or they are outside the donor hospital, the allocation has to be certified by the concerned SOTO. Or if we have a system below that, that is the JTCC type system, so they will allocate those organs. So this is how it is done. And regarding the brainstem death certification panel, at present there is a system of approval of those experts which are included in the brainstem death. So the two experts, so like one is a head of the institution who is not required to be approved. The second is the treating doctor who are not required to be approved, but the other two doctors. So one is a neurosurgeon or a neurologist if not available, an anesthetist or intensivist. So that is another category. So then fourth category is the authorized specialist, like a critical care specialist or a anesthetist, intensivist, who are not part of the transplant team. So and we always advise every hospital to have a list of experts who are on the panel of that hospital. Like PGI Chandigarh, if I see the brain death committee, their committee, each category has around 50 experts. Like this neurosurgeon, neurologist, if not available, so they have around 50 people listed over there. And then the authorized specialist again has 50 more experts. So all these people, whenever we can put them on by rotation on duty. Like today, it is your turn to, if there is a possible donor comes, a potential donor comes, so you will certify, you will check. And we have to see that these people are exposed to the brainstem death certification, or if they are not well acquainted, they should be trained. Some kind of a training or system of accreditation of these experts is also required. And but these experts, these two categories of experts, they have to be approved by the concerned, again, state appropriate authority, which is giving the license to the hospital. So same authority will approve these list of hospital. The hospital we propose the list of experts, and we always advise that please send a consent of these experts that they are agreeing to be on the panel of the brainstem death board of that for this particular hospital, so that later on, to avoid some kind of a legal issue, tomorrow they may say ki I did not give my consent. Or so just to have accountability, we always advise to have a consent form taken from these experts in advance, and also their copy of the highest degree which they are having, and that should be sent to the state appropriate authority, and the state appropriate authority will just issue a approval letter based on the proposal from the hospital. So this is how it is done. And networking, we also maintain a national registry. Every hospital which is doing transplant and donation, they are required to, enter their data in the national registry. That data means the data of the donors and the recipients of all types of organs and all types of tissues. So that is the law of the land. And these net registry is we are trying to have a single software to enter this data at the national level. And we want every state to be on board to the same software. And allocation power will be at the state level. And once the state is not able to utilize that organ, then it goes to the regional level, that roto level, and then if they are not able to utilize, it goes to the national level. So this is how the system works in the country, and it is now quite functional, and we are trying to make it more robust in future.
Thank you, sir. Very nicely explained, because it's very easy for the tier one, tier two city to know the system. But when we approaches the tier three city, they are really there's a problem. They don't know whom to approach. So as you said, either the local authority, then maybe not the state authority. If at all there's a problem, they can approach the national authority and get it done and have the guidance from you all. So as you
And
move,
living donor transplantation, it is approved. Like if it is from a near relative, it is approved by the competent authority, the head of the institution or internal committee of the hospital. And that doesn't require much scrutiny. If it is from a near relative, close family member, like parents, children, a spouse or sibling, or grandparents, grandchildren. And if it is not a near relative, any other person can also donate for the reason of affection and attachment, but that has to be approved by a authorization committee, which has state government representatives.
thank you. So as we move on, this is for Dr. Murli. You so once donor is identified, and now I very nicely explained and crisply explained about the licensing process. So how are organs allocated, and why do we see a variation in donation rates across different states, Dr. Murli?
As Anil Kumar sir has clearly explained, in order to increase the utilization rate to the organs and prevent the wastage of organs, we usually, the communication starts from the hospital where the brain death declaration happened, through the transplant coordinator to the SOTO in the state level. If there is no takers in the state level, it will go to the ROTO. And if there is no takers in regional part, it will go to the NOTO through the National Waiting List Registry. Based on an allocation principles which are pre-declared based on the medical condition as well as the organ specific things like a blood group and medical urgency like a hyperacute liver failure, waiting time and size and age matching and geographical proximity in the case of heart. And certain special categories are also being added from the NOTO recently, like relatives of the donor has been given some priority. Women and pediatric group also has got some additional priority is given to them. One more thing is the first, if there is in the case of lung as in the case of kidney, one lung will be remaining into the into the hospital in which the declaration has happened, and other goes to the common pool. And based on make sure that it is not based on any influence, it is not based on any ability to pay. There is no hospital preferences, and Noto has removed the domiciliary preferences also recently. It varies between why do organ donations vary significantly across the Indian state means there are high performing states like Tamil Nadu, Telangana, Maharashtra, where there is strong SOTO with a well-oiled system, and they will have an NGO backup with the protocolized management protocols. So with the ICU strength and public trust, they can do better than the other states. So there will be some variability across the states because of this strong SOTOs. So we can adopt that policy and we can be reflected. We from Kerala, we adopted transplant policy from Tamil Nadu, from Mohan Foundation 10 years ago, and our rates are being increased now. This is the way we usually do here.
Thank you for the crisp explanation. Now we go to the transport and the logistics. So, Dr. Tariq, we hear lots about the green corridors. They become symbolic of organ donation now in India. How are they actually organized, and what determines whether we use road or air transport?
Well, now that actually really depends on uh, one thing: how how actively do we pursue the uh, the time constraints and how to overcome them. So, whether it is by road, right, or by air, either it's fixed wings versus rotatory, the helicopter, right? Long distances, yes, the aeromedical, the air uh, transport is arranged, and it's with, as far as Delhi is concerned, or maybe the other parts of India also. Indigo is contacted from here, from our hospital. We used to call up the coordinator would call up the airport authorities as well as the airlines. They have a uh, a set of, I think, about half a dozen forms, right? That this is the organ, and the organ is a living organ, and it is not infected. It cannot be kept in a cargo, and so an additional seat is given to the organ for transport. Uh, uh, there is an ambulance waiting. Uh, if it's a retrieval, then there's an ambulance waiting, right? There are no paperwork or anything, or if there are, then it's right away uh, taken care of. Now, when it comes to the road, then you involve the CISF, right? So this coordinator, hospital coordinator, will liaise with the SHO of that area, who will then liaise with the CISF, and the shortest possible distance, and an alternative route also is already there. So the traffic lights and all will be they will be uh, manually, they'll be turned on manually, so that everywhere it's green. The rest of intersection and others, they are stopped for some period of time, and the organ, once retrieved, is uh, directly shifted to theater. That's how. And I think it was probably Hyderabad or somewhere down south as well, that metro railways, the local railways were also, they were also used for quick um, transport of these organs. So it's basically how you plan it, aeromedical versus road. That is um, uh, something like, if it's a distance of 200 kilometers, right, which normally will take about 4 hours. And if you, uh, uh, coordinate well with the police, this timing can be reduced only to 2 hours, 15 minutes or so. So that's the way we do it.
Yeah, thank you very much. Now we move across from organ donation, brain death, to donation after circulatory death, and to an evolving and somewhat more complex domain, that is donation after circulatory death. And Dr. Hall, this is for you. So, what exactly DCD is, and how does it differ from donation after brain death?
So essentially, let me first clarify that DCD is also legally allowed as per our TOHA Act. So let's get that cleared out, that there's nothing illegal in DCD, first and foremost. Second, it is still donation after a death. So the only difference is that here the death is essentially defined by your circulatory stoppage or the circulatory death. So your heart has stopped. So there are two things which matter here. If the heart has stopped, that means that your warm ischemia's time is begin already, and it probably has begun when the blood pressure drops down to 60 systolic or below, when the process of dying. And that's when it becomes time sensitive. So the DCD becomes a time sensitive thing. Now, why are we even worried about it? Because in India, eye donation and skin donation, which are two tissue donations basically, have been widely accepted. Nobody raises an eyebrow if you say that they donated an eye or they donated skin. Nobody raises an eyebrow. So why are we
Do
worried
we have a
about
charger?
when we are talking about
Charger.
donation after death of solid organs? So that's where the question comes up. Now it is perfectly fine to actually donate death as per the criteria laid down, donate organs after circulatory death as per the criteria laid down, and the acceptable medical criteria are the MAST criteria. I think you will have a question coming up into the details of that. Uh, so essentially, what happens is that you have a category of patients in whom you either have a futility of care, which is the most common way of donation after circulatory death, which happens in the world. I've been involved in several of them in Australia when I was there around 15, 16 years ago. And the law of the land there was that you could actually withdraw care for futility, which the law of the land here also is now clear that primary and secondary consent board can give a consent and you can actually withdraw care. While that happens, and while the futility is cleared, and while we are now talking about withdrawal of care, you could ask the patient's family members that would this person would have wanted to donate the organs, or the family might bring it up themselves. And if they say yes, then you could actually put up the entire organ donation process wheel into the motion, and you could go across and withdraw therapy and wait for the heart to stop. 5 minutes of standby time is what we accept in India, and most countries across the world accept, where we wait for the family to actually spend some time with the patient, declare the death, wheel the patient either to the anesthesia room or to the OT directly, where this patient has a big sternotomy incision taken right from the um, from the neck down to the pelvis, and the organs can be taken out. Now that looks like a Maastricht 3 criteria where we have basically got a withdrawal of care, which is not what is going to happen in India very quickly right now. Though there are people who are doing it, and there are at least papers from PGI Chandigarh and a couple of hospitals from Maharashtra and Gujarat who have already done that. But how have they done that? They have done that using something what we call as a normothermic reperfusion, where they have inserted either immediate postmortem or just before the circulatory death happens, cannulas into the groin, where you actually cannulate the femoral artery and the femoral vein, and you circulate through a ECMO-like circuit after the death has happened, so that organ preservation can be done and the patient can be taken up to the theater, and then you could take up the organs. Now, coming to your two questions, how is the circulatory death defined in the context of organ donation? I've clearly said that it's allowed in the TOHACs. There is absolutely no question. The only difference which it has is the time sensitivity, where now the heart has stopped, whereas in brain death, the heart is still circulating. So you need to look at the preservation of the organ function of the organs which are going to be donated. There is a lot of complexity for people to understand thoracic organs, abdominal organs, how to do a normothermic reperfusion and stuff. There are some countries like Spain is the biggest example. Even UK, even Czechoslovakia now are coming for a opt-out system, where there is a presumed consent that every citizen of the country is an organ donor unless they have opted out for it. In such cases, even road traffic accidents, people who are brought in dead or people who die while they are being resuscitated in an acute emergency can be considered for organ donation. We are not a country of that type. We are a country of opt-in. So you need a family consent to decide whether the organ donation will happen or not. That's DCD.
Yes. So thank you about telling us what exactly the DCT means and how it differs from brain death. So coming to you, Dr. Murli, so which types of DCT in the Maastricht classification could realistically be implemented in India?
So Rahul sir clearly pointed out it is Maastricht 3. That is the control version. That is Maastricht 3. In control, which is seems to be ethically correct because WLST is permitted in India, and as per the Supreme Court ruling in 2018 and 2021, and donation after cardiac death, there is death has been certified by the cardiac. There is no separate brain death declaration is needed. So there is no legal ambiguity as well as there is no conflict of interest is also there. One more thing is logistically, it happens very close to the operation theater or in the ICU room, so that there will be a predictable predictable warm ischemia time so that the preservation can be done in such a way that with the proper consent and all, so that the better organ donation process will also happen. As Rahul sir pointed out, there are success stories from three institutions. One is AIMS and another from Gujarat and also from the Chandigarh. They have done so many cases, but the catches lies in many ways. It has there is a legal ambiguity. Noto doesn't gives us a clear cut idea how to proceed in the DCD state. That is the legal ambiguity that has to be cleared out. Next one is the low public awareness and lack of guidelines and limited physician knowledge and poor ICU infrastructure. As Rahul sir pointed out, it is normothermic regional perfusion as well as DPP can also be done in certain cases. So we have to adopt a policy which suits to the DCD so that the organ pool can be increased above or matching to that of DBD. That's what the Maastricht 3 is the best one.
So yeah, just for the sake of the participants, so as we spoke about the DCG, the master classification has been classified into uncontrolled and controlled one. And if you look at this chart, the uncontrolled one, we have category 1, 2, and 5. And the controlled one, we have the category 3 and 4. And as nicely explained by Dr. Raul sir and Dr. Murli, the controlled one is the one we can actually practice. And understanding these categories is crucial for developing appropriate protocols. So particularly category 3 represents the greatest opportunity for expanding donation in India to systematic withdrawal of life-sustaining treatment protocols. And then we have to do all this as explained by both of them. Thank you very much. As we move ahead to our second last question. So this is for you, Dr. Anil, and partly has been answered. So is the DCT legally permissible under TOTA Act in India, and how might its introduction influence public understanding and trust in organ donation? Dr. Anil, you have to unmute yourself, sir.
So this DCD is legally permissible in India because if you look at the definitions, we have a definition by the deceased donor. So deceased donor means is the absence of signs of life, whether in the terms of either because of brainstem death or in a cardiopulmonary sense. So it is very clearly mentioned. So, and in the consent form also, if you see, when we are seeking consent from the family, there also it is mentioned that they are giving consent for donation after brainstem death or even oblique normal death also. It is mentioned over there. So DCD is again, it has to be like for better outcomes, we should have a controlled DCD situation and where we do the systematic withdrawal of the life support, which is now permitted by the Honorable Supreme Court in its guidelines through the judgment which was given on 24 January 2023. So that judgment has paved the way for DCT, but it is still withdrawal of the life support is not in practice as it should have been, because many few hospitals are only have started doing the withdrawal. So that is one big limitation which is there. And once the withdrawal is there, so you get a time to even identify the patients which are going to receive these organs. And you also have, but certain principles they have to be followed. That we cannot do any intervention to hasten the death. So any anti-mortem intervention before you put any, so a donor has to be dead. So because in our law or as per the Supreme Court guidelines, only the withdrawal of the life support is required. No intervention can be done which which hastens the process of death or person becoming dead fast. So that is very clear. Second is the donor has to be dead before we allow any kind of retrieval, and after death also minimum 5 minutes of standoff period, which Dr. Rahul has also mentioned in his that should be followed. So like intervention means like we have to give heparin, we have to put in the cannula lines. Perhaps those will not affect hasten the process of death. And here definitely the warm ischemia time is increased. So that has to be taken care of. by rapid retrieval or by doing the local allocation of the organs wherever, like, so that we are further not increasing the damage to the. And there are techniques like organ perfusion and NRP, which is to re-establish the circulation after the death has been certified cardio through the like two cases have been done of the NRP, normo-regional perfusion, where we have tried to re-establish the circulation through a NRP circuit. And that is mainly to, so that we are able to preserve these organs. They do not suffer from the ischemic damage, and we are able to harvest and utilize these organs also. DCD world over has been increasing in past 4 to 5 years, and the percentage of organs which are being coming from the DCD donations is increasing. And India, it is not that much as of now. We want to, leverage on the DCD protocols also. Many consensus paper have been released, and we hope that we should be able to release the guidelines based on those consensus which have reached. Nationally, we can release those guidelines. We will try to release the guidelines as early as possible, but legally it is permissible. There is no ambiguity about it, and one can do DCD donation, preferably through the withdrawal process, where we are, doing gradual withdrawal and causing least damage to the organs.
So very nicely explained, sir. I mean, it's very much permissible, and this is the way we can increase our organ pools. And as the withdrawal is being now systematically understood by us, it will be practiced widely. And if we understand the DCD also, then we'll try to explain and put it across to the relatives and might increase our pool. So as we come to the last one, this is for you, Dr. Zidpe sir. So finally, a broader and perhaps the most important question. So how do we build trust in organ donation across hospital communities, various cultures, considering India as a heterogeneous country in terms of the cultures, religion, while addressing myths and misinformation?
I think, Bharat, this question should be answered by the each and every faculty who are there, because
Yes.
everybody is working. My take is that very simple. It's a dynamic process. You have to be continuously doing the awareness, training, communication, building the trust in the community, building a trust amongst the consultants, building a trust among the patient and the relatives relation. Busting a lot. We need to do the lot of busting of the myths. There are so many myths around the brain death. Like recent, these newspaper news are pushing the program very badly. Like the brain death patient to the pothole get the consciousness. These are all myths. These are all myths. We should strongly explain, defend, and make the community aware about that. Brain dead is a dead, and all these are probably there is some issues in the system or the technical this thing. So busting the myth is a must. Continuous communications with your near dear ones, your relatives, your patients is must. Building a trust is must, and it's a dynamic process. It's not one webinar, one lecture, or one day observation. Throughout the 365, and whichever the years you are practicing this field, go on talking about the organ donation, and the brain death is a way forward for our country, whether it is a diverse country or whether it is a huge country.
Pandit sir?
I think the best way to build trust across the community and hospitals is to first build a knowledge base for doctors. I think the doctors are the biggest problem in our whole jigsaw, is actually because the doctors are really ill-informed. And we use jargons, we use words which are not consistent. People have half-baked knowledge, and we actually use this organ donation in a very beg your pardon, brain death in a very, very loose way. So if all of us as doctors have got understanding of brain death, and there is an acceptance that brain death is death among doctors itself, all faculties from MBBS to a super specialist, then I think the trust in the community will start building automatically. India is a diverse country. You have communities, you have cultures, you have religions, there are myths, there are fears, and there are misinformation. You've covered all of that in your question. Unless and until the people they trust the most, which is the doctor in their hour of grief, if all of us are speaking a different language, why would they trust on us? Although it doesn't help that the newspaper and the news media in the country sensationalizes things in a disproportionate way. So we need to be very clear that when you have a good outcome, you also talk about it in the right context at the right platform. So when somebody has donated and the press does it quite well as well. Most of the organ donors are well recognized and the families are well recognized in the local media and the press. I really salute those organ donors and organ donors' families who come across in their hour of grief and actually decide to donate the organs of their loved ones. I think bigger than that, there can't be any trust. So I think those people are actually the biggest flag bearers of the trust that they trusted us as doctors, as hospitals, as medical professionals while doing it. I would just keep positive talk as the most important thing and the doctor's acceptance as the most important thing. These are the two things. If we can do it, our organ donation program will become a bigger success. Currently, the medical fraternity is the bigger problem. Community is not the bigger problem.
Dr. Murli?
Mr. Rahul just said, if you can include organ donation process or brain death, the clarity on brain death in the UG curriculum, so as we can avoid this silent brain death, which is occurring in the most neurology as well as neurosurgery ICUs, that can also be prevented. And we can also conduct community awareness program involving the religious leaders so that these taboos, religious taboos and cultural beliefs can also be countered in such a way that we can have these community programs. Along with the doctors, the community has to be addressed to counter this.
Dr. Tariq? You have to unmute yourself. You have to unmute yourself. We can't hear you. Yes.
Yes, yes. Can you hear me now?
Yeah, now it's good.
Okay, so I completely agree with what Dr. Rao said and others as well. See, I've built more enemies amongst doctors than I have amongst administrators. So uh, I think the best thing would be that a curriculum both for undergraduates, postgraduates, as well as position statements from ISCCM as well as NATO. NATO is very important. Giving uh, the legal codes as well, and all of that, let it be drafted in very simple language so that everybody can understand. Here, the legal terms and everyone, especially I would say neurologists and internists, they come up with their own interpretation of the various steps of brain death, and uh, uh, every step is becomes an obstacle. So that's why I say that NATO and ICC have to have some position statements drafted in very simple language. That's what I have to say.
Dr. Anil, now last statement is for you.
Yeah,
Then
yeah.
also I have a request to make.
So
So I thought I
basically,
should last.
across the hospitals, you have very well pointed out that our doctor community, they have to be, talking in same language, and they have to be aware of the process. Many times, one time I received a request from a surgeon who is working in Delhi, and he called me that there is a patient available at one of his relative has died at home, and he wants to donate kidney. And the call was made 5 hours after the cardiac death happened at home. And so, even not being aware that such a organ donation cannot happen at home. So, such kind of awareness, lack of awareness is there among the doctors community. So that should not be there. If they are not aware, then how they are going to guide others? And they should be talking in the scientific language. The same language should not create any kind of a, ambiguity about the brainstem death process, which is there, which is well recognized legally as well as internationally. And so that's why the awareness programs in the hospitals, regular of the resident, particularly the doctors who are changing, the resident doctors, the regular awareness programs and regular courses for them before even they receive their first salary as a resident should be mandatorily conducted by the hospitals with the support of the experts. Not only for the doctors, but for all the hospital staff, they should be well aware. And the second is the hospital should be ready when the family is saying yes to the donation. So they should be ready with everything. What is involved in the process? Many times it has happened the families are ready to donate, but hospital is not ready.
Good.
So that is also very important that our hospital should be ready to receive, say yes that we will be going ahead with this donation, and they have logistics systems in place. And organ donation is a right of every family. We should respect that right. And we as a doctor community or as a hospital community, we should be facilitating those rights of the family, and we should be very transparent and informing the family. And while communicating, we should say that the soul is going, but these organs are live organs which are going to survive and will continue to give lives to others. So that message that these organs are live organs and we should not destroy them, that should be very well communicated to the family. And definitely all the myths, fears, and misinformation, we can say currently we have a 24/7 helpline also, 1800 114 770, where we have trained counselors available who can guide them regarding the entire process of donation. And also we have a pledge registry functional where people can come forward and register to donate their organs after death. So that is also functional. But currently, because the numbers are, we have launched it very just 2 years, 2.5 years back. So currently the number is around going to be around 5 lakh. But it requires Aadhaar number, and so that registry is functional. And if you look at the data where the people register as a driving when they apply for driving license. So currently we have around 60 lakh people who have said yes to donation in last 5 years. So that data we have got from the Transport Ministry, and that is not a very huge data. It is around somewhere 15 to 16% of the entire applicants who applied. But there it is just because they are just doing it, they are not getting any information. We have to provide correct information, correct messages, clear messages, short, crisp messages, which is delivered to the individuals and communities as well as the religious leaders. They should be, realizing that these organs, the people are going to survive. These organs are going to survive, and they are not going away. There are people who, died 25 years back, but their heart is still beating. So those kind of stories, and we highlight them quite often. They have to be, disseminated well through all platforms, and giving an opportunity to them to pledge to donate organs. So that is also functional through the government registry based on their Aadhaar authentication, Aadhaar verified. So we need to all promote that pledge registration also. So that's all I wanted to communicate. Yeah.
No, sir, thank you very much. We all know, sir, you've done an amazing job in passing on this information, increasing. You've been very flexible with the approaches. We all hear those stories. The request we wanted to make is, as Dr. Kapil Zirpe sir and Dr. Pandit sir spoke about those myths, what came recently in the newspaper, we keep getting these kind of news. So when the press conference happens from the apex body and deny those or uh, have clear information what exactly happened, then it would be easier for us to convince the public, because with one news, public will understand the brain dead patient also gets converted, maybe come into the life. So it has to come from the authority from you. Yes, this news was
Yeah.
not right, understanding was
Actually,
not right. It will
yeah,
make a
because the
difference.
news was not very clear, we have sought investigation by the government of UP into that incident which has been reported, and like whether this hospital was even, eligible to certify somebody as
Brain
a
dead.
brain dead person or not, whether the doctor was even approved for certifying. So, and whether actually they communicated like that, or this kind was a miscommunication which was there. And we have also, written to the Times of India to, just explain, but still we are waiting for their,
So
responses.
clarity from the
Hope
response
to,
from the apex body will make a difference. And even the if
yeah,
that
yeah.
kind of statement comes in, then as every panelist agreed, doctor needs to be very clear. So doctor will be very cautious in using that word if they understand this has been watching.
Yeah, yeah,
Be
yeah, yeah,
careful.
yeah. They should be well aware of when they are saying brain dead, somebody has brain dead. And
Yeah.
we had like films like Gabbar is Back, which was, Akshay Kumar had. And there he, he said ki this particular hospital declared him brain dead and you are treating a brain dead. He had questioned that. So that kind of films have also come. But definitely, hospital systems should be perfect. We should
Okay.
have systems of communication coming from the ICU, from the critical care experts, as well as the critical care nurses who are working. Whenever there is when they should, send a alert regarding a possible donor available in the ICU, and the hospital should have a system of, acting on those alerts, and the brain death committee moving to the ICU to check those, whatever alerts they receive. So those protocols should be, in place in
Yeah.
all the hospitals to be ready to receive donations.
That's what, sir. As we have the Code Blue committee, and the NABH recognition doesn't come without that committee being in presence. So if you could approach the NABH and they can have a brain dead code kind of a thing. So of course, if we have that kind of a code, then the education will also come in, and every hospital adopt it if it becomes necessary for the NABH accreditation.
Yeah.
Yes.
But
So
the irony is that even if the news gets corrected by Dr. Anil Kumar sir and gets published, they will publish it in one corner, not the full half-page news that they published.
Yeah.
That's the irony. That the good thing always is small, sensational thing is
is
big
always
front
big.
page
Yeah,
news.
they always want to
Live.
Apart
sensationalize.
from us doctors, nobody will forward that message.
Yes.
Yeah.
Because really people who would forward it would be wanting to give the correct information. And I'm sure Dr. Anil Kumar will write it and publish it, and he will have his news published in a few days' time, because we all know it can't be true.
True. Yes.
But the reach of that versus the reach of the false news, there's a huge difference. That's the
Difference.
Yeah.
problem.
That's the point. So, as we conclude, I think one message stands out very clear. We had a very clear messages over here. Brainstem death has to be decoupled from the organ donation. If there's a brainstem death identified, there are two ways out of it. One is organ donation. Second is withdrawal of the support. Apnea doesn't need a consent. So, as an intensivist, we are in a unique position not only to diagnose brain death with certainty, but also to guide families with compassion and clarity. And if we get that moment right, we don't just save one life, we transform many. And thank you to our esteemed panelists for sharing the insights. And thank you to all of you for being part of this meaningful discussion. Thank you once again. Let's continue to work together to strengthen organ donation, to strengthen the compensation, what we provide to the family, and save more lives in the coming future. Thank you to all the panelists. Thank you very
Thank
much.
you. Thank you
Thank you
and
very
good
much.
Thank
night.
Thank you.
you.
Thank you.
Bye.
Bye, sir.
Bye.
Thank you.
Bye. Bye. Okay. Good night.
Good night, sir. Good night. Thanks.